We're going to get started again with our next part of this session. Our next speaker is Tyler Erath. Dr. Erath is a research fellow at the University of Vermont in the Department of Psychiatry and in the Vermont Center on Behavior and Health. He received his PhD in behavioral psychology from the University of Kansas in 2021. As a behavioral scientist, his research is broadly focused on substance use disorders and health disparities. A central tenet that connects his research aspirations is a desire to integrate evidence-based practices into real-world community settings. His current research includes collaborative work with local harm reduction and syringe service programs, examining substance use and treatment implementation for service recipients. In addition, he's working on developing 2 lines of tobacco research, including systematic reviews, experimental studies, and epidemiological research. And today his talk is entitled Rurality and Gender Differences in Adolescent Cigarette Smoking. Tyler.
And I have the opposite problem of having to raise this as high as it'll go. So wanted to start out with thanking some collaborators who have made this research possible. And as it relates to disclosures, I have none to declare for you today. So as we've heard from some of the other wonderful presentations, cigarette smoking continues to be a leading cause of preventable death and disease in the United States. And I'm going to be talking specifically today around youth tobacco use. And so what we know as it relates to youth is that about 9 in every 10 adults who end up smoking daily started out smoking when they were adolescents, so before the age of 18. And much effort really has been directed towards reducing cigarette smoking among adolescents. And this has been done with great effect. So in fact, these efforts are actually now associated with record low prevalence rates, which is often an under-recognized and underappreciated and notable public health achievement that we should be celebrating. So more specifically, youth cigarette smoking has dramatically decreased over the last 3 or so decades. So for example, the data depicted here are from the longstanding Monitoring the Future survey. So depicted on the left-hand side of the screen is past month cigarette use, where if you look at it, the years about 1996 to 98, past month smoking amongst 8th graders was at about 20%. This goes up to 30% for 10th graders, and then at about 35% for 12th graders. And then if you click over all the way down at 2022, this is down to just 0.8%, 1.7%, and 4% for 8th, 10th, and 12th graders, respectively. And then for daily use, we also see a similar trend where the decrease amongst 8th graders has gone from about 9% down to 0.3%. For 10th graders, this is 18% down to 0.7%. And then for 12th grade students, this rate's gone down from about a quarter to 1.6%. And so one critical question that we've been interested in is whether these declines in smoking prevalence are observed across all populations or whether at-risk groups disproportionately account for them. And so despite this striking decline, there is still some unknowns about the disparities in adolescent cigarette smoking. And one example is how and in what ways the accumulation of various sorts of psychosocial and health-related risk factors might predict cigarette use. And so among adults, we do know that smoking risk increases in an orderly manner as a function of the total number of risks that someone experiences, which has been referred to in the literature as cumulative disadvantage. In populations with higher cumulative risk or cumulative disadvantage have slower rates of decline in smoking prevalence. So one of the questions that we were interested in is whether similar trends might be observed in adolescent smoking, which was currently unknown. And the reason this might be impactful is to get a better understanding of that relationship between disparities and adolescent cigarette smoking risk. This work could be used to help inform prevention and treatment interventions to help eliminate youth cigarette smoking. So to do so, we examine trends and disparities in adolescent cigarette smoking, and then whether what we conceptualize as a cumulative risk model that characterized adult smoking, whether that could extend to youth. And so here we examined associations between cumulative risk and looking at that on past month and daily cigarette smoking prevalence, and looking at this across time with daily smoking indicative of the onset of chronic smoking and some of those associated adverse health outcomes that come along with it. So this sample included a nationally representative group of adolescents from 12 to 17 years old who participated in the National Survey on Drug Use and Health, or might refer to that as NSDUH for short. And so the time period we were looking at was 2002 to 2019. And so the National Survey on Drug Use and Health is an annual cross-sectional survey that residents from all 50 US states participate in, as well as DC. And it assesses various types of substance use, so alcohol, tobacco, other drug use, and also looks at other health and mental health related variables. And so these data were collected via face-to-face household interviews. The primary outcomes that we were looking at were past month and daily cigarette smoking. And looking at that, for each of these outcomes, we were actually looking at it in two different ways. So as a function of prevalence or just absolute rates, and then as a proportional change across the study period, where we were setting it up as 2-year bins. Each 2 years were aggregated, and then using that baseline of 2002 and 2003, the proportional change from that time period. And so the risk factors were all known to be risk factors based on empirical literature, and this included variables like alcohol binge drinking, cannabis use, conduct problems, poor academic performance as some of those examples. And then for each participant, their risk factors were added together to calculate a risk index composite measure, or a measure of cumulative risk. And so participants were categorized into 3 different groups. So those with 0, 1, or 2 risk were categorized as low risk, those with 3 or 4 as moderate risk, and then those with 5 or more as high risk. And so the covariates, as noted here, included gender, race, ethnicity, age, and rural residence. And I did want to note that for the variables that I'll be discussing here, I'll be using the language that's used in NSDUH. And so one important note regarding gender is that NSDUH does not assess sex and gender as 2 separate variables. So just wanted to make that note. And so here's data regarding the descriptive statistics for those outcomes, which looking at sociodemographics and then also how it relates to cumulative risk. So all the models, next slide is the data, sorry. And then all models were used sampling weights based on the US Census. The data were aggregated, like I mentioned, into 2-year bins. And then with respect to the analyses, so logistic regression was used to examine whether past month and daily smoking prevalence varied by these risk categories. And then linear regression analyses were used to test whether the proportional change in past month and daily smoking differed as a function of those sociodemographics and cumulative risk category. So regarding those sociodemographics, and then looking at some of the differences of smoking amongst the covariates, we did observe some significant differences in past month and daily smoking prevalence. So these included significant differences by race, ethnicity, age, family income, and then 2 that I've highlighted here as it relates to later discussion, which are gender and rural residents. Regarding the risk group makeup, so the weighted proportion of individuals that were in each of the groups was about 84.3% for individuals in that low risk category. Moderate risk comprised 12.8% of individuals, and then 2.9% of individuals were in that high risk category. And so here, graphs A and B depict the data for past month and daily smoking prevalence. And this was across time in those 2-year bins. And so we have year on the x-axis, and then on the y-axis is percent prevalence. And I did just want to note that for this graph and then for subsequent graphs, the y-axis will be different for past month smoking and for daily smoking. So for both past month and daily smoking, the greatest risks occurred, like one might expect, amongst those in the high risk category. So this was across the study period from 2002 all the way through 2019. And then this was followed in an orderly manner by those in the moderate risk and then the low risk categories. And so these tables underneath each graph list the smoking prevalence for each group, collapse across the study period, and then adjusted odds ratios. So for past month smoking, when compared to the low risk group, the adjusted odds ratio for smoking in that moderate risk group was 17, and this goes up to 72 when compared in the high risk group to the low risk group. For daily smoking, when compared to the low risk group, the adjusted odds ratio for smoking in the moderate risk group was 29, and then 137 in the high risk group. And so graph C and D here depict data for the proportional change in prevalence for past month and daily smoking. And so these data show a decline that differed amongst the different cumulative risk categories. So the low risk group here showed both the quickest and the steepest proportional decline, followed by the moderate and high groups. And so the differences in the rate of decline here did significantly differ between all groups and group comparisons. So taken together, what these data indicated to us was that smoking remained most prevalent amongst adolescents with greater cumulative risk, and then also that the least proportional decline was occurring amongst those with the greatest cumulative risk. And it is important to note that these differences in both past month and daily smoking occurred in this cumulative risk model when everything was observed and controlling for those covariates of sociodemographics and family outcome or family income. So there are several implications from these findings. First is that this study provided novel evidence from a nationally representative sample that youth smoking risk cumulatively increased corresponding to those number of psychosocial and health risks that someone experiences. Second, this model was a model that had been demonstrated in adults and now has been extended to assessing smoking risk in youth. And then third, this study provides evidence that while I noted those record-setting reductions in cigarette smoking among U.S. adolescents, they nevertheless do still continue to include disparities. And among those, two that we were particularly interested in were differences in youth smoking prevalence by gender and then rural residents. So learning from these data and then diving into the literature, we did just want to look to see what had been reported on rurality or rural residents and gender differences in youth cigarette smoking. And so some research has examined this rural-urban disparity in youth smoking, where most of these studies focused on past month prevalence and limited or no studies we could find that had looked at daily smoking. And then again, most of these studies were looking at those overall rural-urban disparities, and to our knowledge, no studies have looked at examining the role and interaction of gender on those differences in youth smoking. So the purpose here then was to look at examining just that and specifically examining the roles of gender and rural residents on past month and daily smoking. So again, here we were using the NISDA data set with survey years from 2002 through 2019. And so gender was assessed by the question listed on the screen here of, are you or is this person male or female? And then rural residents was assessed using rural-urban continuum codes from the 2000 census for survey years 2002 through 2014. And then this was updated for data from 2015 to 2019 using the 2013 Office of Management and Budget classifications. And so all data here were again aggregated into 2-year bins, sampling weights were applied. And with respect to those analyses, logistic regression analyses were used to test whether past month and daily smoking varied by gender and rural residents across time. And then depending on those results, pairwise contrasts were then conducted to look at the comparisons based on the interaction results. And so the sociodemographics are listed on the table here. And so the sample included a total of 298,530 youth. Approximately 49% were female, 51% were male. And then with respect to rural residents, 78% were residing in a urban setting and 21.6 were reported as living in a rural setting. Regarding the findings, for both past month and daily smoking, we did observe significant main effects for rural residents and then for time. And then we also found several significant two-way interactions here, which I'll describe those in more detail. And so one of the significant two-way interactions that was observed was for this interaction between rural residents and time. And this was observed for both past month and daily cigarette smoking. So specifically, in this, looking at this rural residents by time interaction effect, we also found a difference for both daily and past month smoking. So again, here year is listed on the x-axis, and percent prevalence is on the y-axis. And scaling, again, a little bit different for each outcome. And so on the bottom row there is some of the test statistics and adjusted odds ratios for each outcome, along with the 95% confidence intervals. And as you can see, prevalence across both outcomes decreased across the study period, where for past month smoking, prevalence among rural youth both started and remained higher throughout the study period when compared to urban peers. And this disparity was also observed for daily smoking, though it does appear that that gap was wider early on and is narrowed some over time. So then I wanted to drill into that interaction effect and look at, for past month smoking, looking at differences in that based on this rural residents by time interaction. So here what's being compared is the difference between rural males and females to their urban peers. And so what you'll see is that the trends here that were observed are similar to that overall interaction effect, with a significant difference for both males and females. So here prevalence started and remained higher for the rural youth when compared to the urban youth. And then so this figure looks at the daily smoking interaction comparison, which we did see a significant difference among rural and urban males, which is depicted on this figure here. And we did not find a significant difference in daily smoking for rural or in urban females. And the other significant two-way interaction we found was for this interaction between gender and time, specifically for past month smoking, but not for daily smoking. And so here's those data in graph form. So these data depict both past month and daily smoking in this gender by time interaction. So here we were comparing males to their female peers. And again, years on the x-axis, percent prevalence on the y-axis. And so we did observe a gender difference for past month smoking over time. And that's on the left-hand side of the screen. But then for daily smoking, we did not see a significant difference. And so for past month smoking, this prevalence among female youth started just a bit higher in 2002, 2003, and then ended a bit lower in 2018, 2019. And that's when comparing it to those male peers. And so these graphs depict the pairwise comparisons, drilling into that data here for past month smoking. And the trends here overall were similar to that overall interaction effect, with a significant difference for both rural and urban youth. So for rural youth, smoking prevalence among females started higher early on in the study period, so 2002, 2003, and ended lower by the end in 2018, 2019. And so a similar trend was observed for urban females versus urban males. And one interesting finding is that among these subgroups, it actually appears that the largest decrease in prevalence across the study period occurred amongst rural females. So they started out the highest early on here, but ended up with pretty similar rates to their urban peers. Taken together, these data help to provide some evidence from a nationally representative sample that youth smoking prevalence differs by rural residents and gender across time. And so we did find that rural-urban disparity in past month cigarette smoking, which persisted throughout the study period, and this occurred for both males and females. And additionally, we observed a rural-urban disparity in daily cigarette smoking for males, but not for females. And it does appear that this gap appears to be closing across the study period. And then we also found disparities in past month smoking by gender over time. And so greater declines occurred in both rural and urban females when compared to their male counterparts. Regarding just a couple of limitations, so just noting that NISDA is a cross-sectional survey, so the interactions and effects we're talking about here are not in the causal sense. Smoking status is also determined by self-report. And then just wanted to also make a note that, like I mentioned earlier regarding the role of gender here, and that NISDA does not assess sex and gender as separate variables. So thinking about it more generally and with respect to implications, one of the overall and kind of overarching implications across both of these findings is that as adolescent cigarette smoking continues to move towards what has been conceptualized in the literature as the tobacco endgame, for efficiency, future efforts should work to prioritize populations with greater known disparities, and these are just two examples of how that might be done. Thanks for your time.
Next speaker is Steve Higgins. Steve is the director of the Vermont Center on Behavior and Health at the Larner College of Medicine here at UVM, and is the principal investigator on 5 NIH grants on the general topic of behavior and health, including the UVM Center of Biomedical Research Excellence, or COBRE, and the Tobacco Center on Regulatory Science, or TCORS. He's a distinguished professor and the Virginia H. Donaldson Endowed Professor of Translational Science in the Departments of Psychiatry and Psychological Science. His research centers around behavioral economics and behavioral pharmacology to investigate tobacco, substance abuse, and other health-related risk behaviors in vulnerable populations. Dr. Higgins's projects focus on examining mechanisms underpinning vulnerability to tobacco and improving health outcomes, treatment interventions to reduce them and improve health outcomes, and regulatory science. He has held many national scientific leadership positions and is the author of more than 450 journal articles and invited book chapters, and editor of dozens of volumes and therapist manuals on behavior and health. And his title today is Examining Disparities in Smoking Among Adult, Rural versus Urban Women by Chronological Age, 2002 to 2019.
Thank you, sir. Yeah, it's a pleasure to be able to present some data. So you see the title here, looking at disparities in smoking among adult rural versus urban women by chronological age, 2002 to 2019. I'm going to use NSDA just like Tyler did. One thing I would add is about these years is NSDA had different methods prior to 2002 and after 2019. They changed their methods. So this is the longest period of time where there's a common set of methods, this 2002 through 19. So this slide shouldn't be there. So collaborators, Fang Chen and Tyler Erath. Fang is here. So anything that's wrong, I'm gonna blame these guys. No. I have grant support and disclosures, just the research, nothing else. So these U.S. rural health disparities have been concerned since the 1980s. Rural communities on average have greater prevalence of risky health behaviors, worse outcomes than more urban regions with inadequate healthcare access, a notable contributor and an actionable contributor. When the famous 1964 Surgeon General's report on smoking and cancer was released, smoking prevalence was lower in rural than urban regions for both men and women. And smoking has decreased considerably in both areas since 1964, but more so in the urban than the rural populations. So my overarching aim here today is to systematically review or share a series of reports we've done on this topic and reproductive age women. And then today I'm going to share the new data on women, adult women across all age brackets. So we've conducted a series of cross-sectional studies examining these rural-urban disparities in cigarette smoking using NSDA. Tyler detailed a lot of that survey. This first study we did was in 2018, led by Antonio Cepeda Benito, and it examined gender differences in smoking prevalence across years 2007 to 14, demonstrating that the greatest disparity was seen among rural women. And then Tyler Nyber and colleagues examined smoking in years 2007 to 16, also using NSDA, demonstrating that these rural-urban disparities were occurring among women of reproductive age, which is really a population of great interest to me because of the implications for multi-generational adverse effects. And the disparity is evident in both women who are not currently pregnant and those who are. And then most recently, we followed up with a published study, most recently in terms of our publications. We looked at smoking prevalence and quit ratios in women of reproductive age in 2002 to 2019. And so today, it's kind of the next step in this programmatic series of studies. We're going to look at women from 18 to 65 plus. All right, so shared methods. Tyler really detailed a lot of this. Current smoking is somebody who reports using in the past 30 days, and also they've used at least 100, more than or at least 100 cigarettes lifetime. And the adult women is 18 years and above. And we use standard criteria for discerning rural from metropolitan, micropolitan, and those criteria or those designations are from the actual NSDA survey. We are adjusting for race, ethnicity, educational attainment, and income in the data I'll show you. And we're looking at I already mentioned smoking prevalence and quit ratios. Today, I'm not going to be able to share the quit ratios because we haven't calculated them yet, but we will before we publish this data. All right, so I'll show you what caught our attention in the Cepeda-Benito data. And this, I have to say, this was fun because I'm not showing you the data we were doing where we hadn't parsed it by gender. And so this is the first one where we get on to this disparity that's disproportionately impacting rural women. So what this is these showing prevalence rates adjusted for all the potential confounders I already mentioned. And what I want you to see is, I don't know where, I have that pointer. So there's curves. So there's 4 curves, and you can see the legend here. But the one that's standing apart from the others is the rural women, which is flat. Urban women are going down, rural men, urban men, they're going down over time. And so that caught our attention and has, implications when you project out that they're going to be disproportionately impacted. So then we, of course, I already mentioned, we have as a group, have a particular interest in women of reproductive age, and especially those who may be pregnant. And so Tyler Nyber's study, what we're showing here is the proportion of people who are smoking, women who are smoking by rurality and urban residence status. And you can see, and they're in 2-year bins, and you can see that the rural smoking prevalence is substantially higher than the urban smoking prevalence throughout the time period. And then what we're looking at here is a breakdown by rural women on the left, and then we're doing pregnancy status by the different symbols. And it looks like the circles are not currently pregnant, and squares are currently pregnant. And what you can see is if you compare the left pregnant and not pregnant to the right, you see the rural disparity. But then the other thing that's important to look is if you look on the right, sorry about that. Get that back. If you look on the right, the space between the not pregnant and pregnant is suggesting that the pregnant women are quitting. And if you look, I don't know what's going on with that, but if you look on the left, there isn't a clear space. So some of that's by smaller ends in the rural that compared to urban, but really a big part of it is the rural women are not quitting as readily when they find out that they're pregnant. So then we follow that up with a longer time span, the 2002 through 2019. And so now we're going to, again, look at smoking prevalence in rural and urban women. And these are women of reproductive age. And you can see, not only a large disparity, but a growing disparity over time. I heard one group put it that like smoking is becoming a rural phenomenon, which isn't totally true, but it captures an important trend that we should be sensitive to. And now I separate that was overall, and now I'm separating them by their pregnancy status. And you can see that this disparity is evident in across pregnancy status. And now quit ratios, and what you're looking at with quit ratio is you report a lifetime smoking status, but you haven't recently smoked. That's the simplest way to put it. And so we have more former smokers in the urban, so that now the urban data points are higher than the rural data points. So significant disparity in quit ratios across the years, with rural women less likely to quit. And now we break them by pregnancy status, and you can see that that disparity in quitting is evident in both those who are not pregnant and those who are pregnant, which is what I was hinting at in the earlier study by Nyber, that we're not doing as well as we should in getting or helping rural pregnant women to quit. All right, so now I'm going to turn to a longer, the same time period, but all the age brackets. So I've mentioned several times our bias in women of reproductive age, for which I think for really good reasons, the can have terrible long-term adverse effects on the exposed children, in utero exposed children. So largely the same methods. The age brackets here are just those that are used in NSDA. Large numbers of women and men, or not women and men, of rural and urban women, and we're controlling for race, ethnicity, educational attainment again. So everything's largely the same as what I've been sharing. And so in the analyses, we have 3 two-way interactions that I'll share with you. No, thank goodness, no 3-way interactions, because they're really hard to understand. And then I'm going to illustrate the interactions graphically. So the first one, collapsing resident across urban and rural residents. There's the interaction of age and time, is that you see decreasing trends over time in the 3 younger age brackets, but not the 2 older, and especially not in the 65 plus. And so truthfully, I'm trying to still understand what that means, but that's what the data shows. And when you get to the 65 plus, this sounds kind of harsh, but it's consistent with what we've been talking about, the carnage of smoking. A lot of the people have died who are continuing to smoke, and fortunately, some have quit. Okay, so the kind of take-home slide is this residence by time, and so you see the collapsing across all the age groups. Among adult women, you see this growing disparity between the rural and the urban, with greater smoking in the rural women. And so what got me here too is, so I'm very interested again in women of reproductive age, but when I look at the adverse health outcomes in that population, I can't help but bump into these disparities also in cardiovascular disease, pulmonary diseases that are impacting rural women. And we have experts, Kate Manson and Sherry Kadanga in our group. So this is a serious thing, is impacting women, adult women of all ages. And then I wanted to show this. I just bumped into this while looking at the other. This is a CDC data on disparities, rural-urban disparities in death rates. And so if you look at the bottom, the women, you see that same shape curve where it starts out small and then it grows over time. So I go back to this graph and then look at this graph at the bottom one on death rates. So, we've been emphasizing the toxicity of smoking, that the shape of those 2 functions isn't coincidental. So very, very serious disparity. All right, and this is the interaction between residence and age, and what is shown is that the disparities, very pronounced in all age groups except this 65 plus. So summaries and conclusion: the rural-urban disparity in smoking is robust and impactful, and contributing to disparities in morbidity, smoking-related cancers, cardiovascular disease, pulmonary disease, and then I showed you a graph on mortality. It's disproportionately impacting women, and it's discernible across all age brackets below 65 years. where previously the disparity could be accounted for by differences in socio-demographic, socioeconomic disparities in the early 2000s and whatnot, over time that's no longer the case. So some of that's suggesting that some of this disparity is the women in the rural regions don't have access to evidence-based tobacco control and tobacco regulatory interventions. And the good thing about that is those things are actionable. So that's a priority for us going forward. Increase access to evidence-based smoking cessation to especially rural women of reproductive age, but rural women generally. And I'll stop there. Thank you.
Our third and final speaker for this part of this session is Grace Kong. Dr. Kong is an associate professor in the Department of Psychiatry at Yale School of Medicine. She has a PhD in clinical psychology with specialization in child and adolescent psychology. Her research is focused on preventing youth tobacco use using a variety of methods, such as qualitative and quantitative strategies, including social media analytics to understand tobacco use and promotional trends to inform policies and to develop novel prevention and cessation interventions. She's also dedicated to preventing tobacco use among marginalized youth, such as youth from low income and communities of color who may experience disproportionate levels of tobacco-related cancer and other illnesses due to tobacco use in the future. She has served as the PI and co-investigator on multiple NIH-funded studies and is committed to training the next generation of independent researchers to use social media to prevent tobacco use and other addictive behaviors to promote positive health behaviors. And her talk is entitled E-Cigarettes and Pregnancy on Social Media, a Content Analysis.
Hello, thank you. So my background, I do a lot of adolescent research, but I'm gonna switch gears a little and talk about e-cigarettes and pregnancy and how it's portrayed on social media. So I did content analysis of this. So let's see here. So I want to acknowledge grant funding source, and I have no conflict of interest to report. So cigarette smoking during pregnancy is linked with adverse health outcomes, and this health effect is well established and also well communicated to the public. The potential health effects of e-cigarettes are less understood. While the clinical and preclinical literature is expanding rapidly in recent years, the field is still new. E-cigarettes share known as well as unique harmful constituents compared to cigarette smoking. Some of the known constituents are nicotine and carbon monoxide. Some of the different constituents are flavor chemicals. Emerging studies show mixed findings. It shows that exclusive e-cigarette use or dual use compared to not using any tobacco increases the risk of adverse perinatal outcomes. But some studies did not observe these associations. So although the data is still incomplete, taken together, the current available evidence, both clinical, epidemiological and preclinical studies have shown that e-cigarette use, whether it's exclusive e-cigarette use or dual e-cigarette use or just combustible cigarette use during pregnancy, most likely poses greater risk than abstaining from all tobacco products, but it may be less harmful than smoking combustible tobacco if the pregnant person switches completely from combustible to e-cigarettes. But much of the focus has been on pregnant people who dual use or who previously smoked cigarettes. And as youth from e-cigarette epidemic are now reaching an age where, a childbirth is possible, pregnancy is possible, understanding perceptions of e-cigarette use during pregnancy is even more crucial. These population might not be, really well aware of dangers of smoking cigarettes. They may be aware of impact I'm sorry, they might not be smoking cigarettes, and they may be aware of cigarette smoking on pregnancy, but not necessarily of impact of e-cigarettes on pregnancy. Understanding perceptions and use trends of e-cigarette use during pregnancy is particularly, again, important because people who grew up with e-cigarettes being prominent products are reaching childbearing ages, and e-cigarettes have really perpetrated the tobacco nicotine market in the United States. So we could turn to social media to understand tobacco use trends and perceptions. And many adults are using social media. So as you see from the graph here, this is showing percentage of each age group that uses at least one social media site. While social media is widely used among adults of many different ages, it's really popular among younger adults who maybe become pregnant. And social media offers insights into emerging tobacco use trends and hard to study topics like e-cigarette use during pregnancy. And studying e-cigarette use and pregnancy on social media may be relevant because pregnant individuals may turn to social media to obtain health advices, particularly for stigmatizing topics that they may feel embarrassed talking to their healthcare providers about. Also, they may be exposed to topics related to e-cigarette use during pregnancy on social media through just social media's algorithm that might push certain content. So if you're pregnant, you're searching for pregnancy content, or if you're vaping and you're searching for vaping content, you might just get this content just through the algorithms. And we do know that social media plays a really important role in shaping people's tobacco use perceptions and behaviors. There's a strong literature showing that that is the case. So in this study, we wanted to understand content related to e-cigarettes and pregnancy on TikTok. And we chose TikTok because of its popularity among young people. And TikTok is a social media platform where users could create videos that are 60 seconds long. They could add music, filters, and effects. And TikTok's algorithm analyzes users' engagement and viewing habits, and they give them sort of the content that they may be interested in. Okay. So to do this, we search for just broad general terms related to e-cigarettes and pregnancy. And we use Amplify to search for these keywords on TikTok, and we obtained the metadata, and we downloaded the videos using talkdownload.com in September 2023. And for each combination search terms, we downloaded 100 unique TikTok posts. Okay. To use in our content analysis, we developed a codebook. We used deductive and inductive approaches, and 4 independent coders viewed 10 to 30 videos independently. And then any differences in codings were discussed until we reached a consensus. And once we finalized the codebook, a single team member coded all the posts using that codebook. So we coded for e-cigarette use during pregnancy, valence, so whether there were pro-vaping during pregnancy, anti-vaping during pregnancy, whether the content was mixed or if it was unclear or neutral. And then among those people who discussed reasons for using e-cigarettes, we noted that, and we also noted reasons for quitting or cutting down e-cigarettes during pregnancy. And we identified people who are featured in these videos, whether they're male, female, and if female, their pregnancy status and the age group. And we also looked at engagement data such as likes, favorites, shares, and downloads. So again, for each combination of e-cigarette and pregnancy, we got 100 unique videos. So we had 600 unique videos in total. And to be eligible, they had to contain content related to pregnancy and vaping. And then we excluded 430 videos because it did not meet one of the criteria. So in together, we had 170 videos. So this is what we found. The green color here represents anti-vaping during pregnancy, and it was 55%. The blue color represents pro-vaping content during pregnancy, that's 13%. And unclear neutral, which is represented in orange, was 27%. And the mixed valence was 5%. This is an engagement metrics. So social media engagement metrics tend to be very positively, highly positively skewed. So we looked at the median and mean and the max. And what we found was that some of these videos were, like more than 500,000 times and shared more than 37,000 times. And we did not find any differences between engagement with the valence of e-cigarette use during pregnancy. So we looked at demographic characteristics of the people who were featured on this TikTok videos. We found that 85% were females. And of the people who were featured, sorry. Okay, something stuck, but 50% were ages between 18 to 30. So of the females who were featured in these videos, we found that 32%, they stated that they were pregnant, but they were not visibly pregnant. 28% were unknown, 24% reported being previously pregnant, and 13% were visibly pregnant, 2% they were stated not pregnant, and 1.4% were trying to get pregnant in the future. And this is a geographic location of where the TikTok posts were being made. So on the right side here, with the blue graph represents the countries. So 67% were from the US, 23% was from Great Britain, Canada, New Zealand, the Philippines, Australia, and Mexico. And what we did was we also tried to see whether e-cigarette valence differ by the country. So we group all the non-US into one group, and then we compare it to US. And then the graph on the left side shows whether videos from non-US and US differ by the e-cigarette during pregnancy valence. And we found that non-US US videos tend to be more anti-vaping. Non-US videos tend to be more pro-vaping and also more likely to be unclear and neutral. So I'll now show you the content related to anti-vaping during pregnancy. There was a lot of content, just testimonials of people quitting during pregnancy. And there was also a lot of content showing people criticizing or shaming people who vape while pregnant, using words like gross, disgusting, trashy, selfish. And there were content informing others not to vape while pregnant, saying it's not safe to vape during pregnant. Vaping during pregnancy increases the chance of miscarriage. And also that vaping lowers fertility and how it negatively impacts male fertility. The other content included informing others not to vape while breastfeeding, saying things like not vaping is a requirement to be a surrogate, and rejecting others' claims that vaping is safe while pregnant. So content related to pro-vaping during pregnancy. There were testimonials of vaping while pregnant. So people actually showing their baby saying that, I vape while pregnant, my baby's fine. Testimonials of switching from cigarette smoking to vaping during pregnancy. Like hearsays, like, my doctor told me or my mom told me that vaping while pregnant is safe. And other content like using vaping as a source of birth control, and also talking about policies in the UK that, pregnant women, if they quit, they could get vouchers for stop smoking. So mixed valence included, sort of mixed content, right? So testimonials of quitting, but that they quit, but they're not going to judge other people if they don't want to quit while they're pregnant. They also talked about secretly vaping while pregnant and feeling really bad for it. And also they were pro-quit vaping, but anti-quitting cold turkey. It also talked about currently vaping while pregnant, but they actually want to quit. The unclear neutral content, a majority of this content just didn't state a position. They were talking about vaping and pregnancy, but like in unrelated ways. Pregnant people were also talking about how they quit, but they're really looking forward to going back to vaping once they're done with their pregnancy, once they give birth. Other content, jokes and sarcasm about stopping vaping while pregnant, celebrity gossip about, celebrities vaping in front of pregnant people, testimonials about being addicted to vaping and try to convince themselves that they're pregnant so they could quit vaping, and just content about it's like none of your business what people do. So among the posts that talked about why they use e-cigarette during pregnancy, we try to identify more of the content. So there was a lot of conversations about withdrawal from nicotine, and quitting cold turkey could hurt the baby, like stress and miscarriage. So that's what they were vaping. And they're talking about recovering from hard drugs. So vaping is actually okay just because this is much safer and easier to do. They talked about how quitting is hard. Quitting, this is a quote that says quitting vaping is harder than people think. Families have done worse and the babies are fine. And they talk about how nicotine is a real addiction. And they also share information that, doctors did not recommend quitting cold turkey, so they're switching to vaping, which the doctor said was perfectly fine. And they also use as a birth control. So these are reasons why people are using e-cigarettes during pregnancy. So we look to see why people are cutting down or quitting e-cigarettes. People talk about cutting down slowly because they think that quitting cold turkey could harm the baby. They quit for baby's health reasons. They didn't want to put their child's health in danger. They didn't want to hurt baby's lungs. And quit for maternal health. It's bad for your health. They don't want to put chemicals in their body. And didn't want to be selfish. They said child didn't want, they didn't choose to come to the world. And so they didn't want to be selfish. So what did we find? We found that both anti and pro e-cigarette use during pregnancy content exists on TikTok, but there's also a lot of mixed or unclear content that exists too. People are sharing testimonials as well as facts. In terms of facts, we know we identify that misinformation exists, such that withdrawal and cold turkey, like hurting the fetus, or that people are using vaping as a form of birth control. In terms of testimonials, it had both motivational and disparaging content. So while some of the contents were motivational, talking about quitting, but others were really shaming people for vaping. And people also said quitting nicotine use is hard, and it really emphasizes the need to help people to quit e-cigarette use while pregnant. I want to acknowledge limitations. When you're analyzing social media data, you're really taking a snapshot of content that exists at the moment, right? The content is constantly changing. And we also don't know whether some of the things that we found here are really representative of what people think and feel. So, social media, I guess one disadvantage is that usually people with strong opinions are the ones who are posting the content. So it's really important to assess this content with real people, right? So really need to understand perception for pregnant people, and not just dual users and cigarette smokers, but really also including exclusive e-cigarette users. We also need to hear from the healthcare providers and community health workers who work with pregnant people to see what kind of information they're providing to pregnant people about e-cigarette use, and also what they're seeing. And we need to understand how social media content affects perceptions and decisions to use, especially stigmatizing content, whether it further stigmatizes the people from asking for help. So, we look to see content related to e-cigarette use during pregnancy, but we're finding things related to prenatal as well as postnatal. For example, fertility, and which is related to breastfeeding. It's really important to broaden the understanding of e-cigarette use to not just focus on the pregnancy, but also prenatal as well as postnatal. We need strategies to correct misinformation. Misinformation gets perpetrated on social media, so really needs ways to counteract that on social media effectively. And we're hearing that people are having a hard time quitting during pregnancy. And even among those people who quit during pregnancy, relapse is very high. So it really provides a unique opportunity to prevent relapse once they have the baby. So I want to acknowledge our research team. We have a multidisciplinary team of tobacco control researchers, qualitative study experts, and computational team. But I want to give a special shout out to Dr. Elise DeVito, who's a women health researcher in the tobacco space. She and I co-developed the study and co-led the study. So thank you.
Thank you very much for these great series of talks. We have plenty of time for questions, so please come to the microphone or.
I just have to.
I'll get us started here. Thanks for a great series of talks. Really exciting to see these studies here. My question is for Grace. So I'm wondering, you talked about the algorithm behind TikTok and how it really funnels different messaging to different people. Do you have any sense as to whether positive, videos that frame vaping during pregnancy as positive versus negative get pushed toward different demographics with that algorithm? Or, if I'm a pregnant person and I vape, would I be more or less likely to get one or the other?
That's a great question. These social media platforms algorithms are proprietary, so we have no idea what they do. But we did several other experiments. So in TikTok, we did experiments. We had someone like really engage with the pro vaping content. And this is not the pregnancy, just like pro vaping, to see whether the algorithm pushes pro vaping content. And for TikTok, it didn't. This is not published because we didn't find any findings. But we also did a similar study, which is published with YouTube. And we had different profiles of like young adults, adolescents, male, female, race, ethnicity, and we did find that there are less differences in how YouTube's algorithm pushed certain content. So for one example is like for youth, there was a lot more anti-vaping content to them. And for young adult males, there was a lot more like modifications of e-cigarette content to them. So, yes, it's happening. We don't know to what extent, because again, it's proprietary information. But so one way to overcome that is to have pregnant people like look at their social media and see what's happening. I think that's one way to sort of address some of that questions, but that's an important question.
Okay, so we have an online question from Samantha Stalford. So the first question is for Tyler and Steve. Could you say more about your decision-making for the rural/non-rural designation used and the strengths and limitations of that designation method? There are many different rurality designations used in health research literature, and I find it helpful to understand the method used when looking at research results, which I know sometimes depends on the level of data available.
Well, truthfully, we use the criteria that are used in that survey, and it's a very highly regarded survey. But my sense of this literature is that there are, there's converging data supporting the disparities that we are reporting, such that I don't think that we're creating that disparity by the criteria used. And so I think that's about the best I could say.
I think it speaks in part to what data are being collected. I know there's a body of research talking about just this, really great paper recently just on this topic of how do you define rurality. With NISDA's data set, it's micropolitan, metropolitan versus a non-metro area. So that's really the designation that is available. But again, some nuance in what does a non-metropolitan area, is that a population of, a county with 5,000 people versus 49,000 people in a small, so, but I do think to Steve's point, the disparity is widely replicated throughout population. So what it's, discerning, it seems to be there.
Yeah, it's the NISDA definition explicitly is a negative definition. So they define metropolitan and micropolitan, and anything that isn't those is by default rural. So, negative definitions are never the greatest. And I guess my best estimate would be that you might find different rates, absolute rates or whatnot, but I think the relative rates, the disparity would be pretty consistent.
Thank you. And then Samantha also had another question for Tyler and Steve again. Did you or do you plan to examine subsets of different geographical regions or states? What have you found or hypothesized to find? This could be helpful to inform local level intervention efforts. For example, rural in West Virginia might look different than rural in California, and those may look different from rural in Vermont.
I have looked at that a little bit with regard to, say, Vermont, which I have a strong interest in, given I live here, versus other states. And again, I think I would come back to, I think in all these regions, if you define rurality, however you might, you're going to find less access to evidence-based interventions for smoking cessation among women, as well as enforcement of regulatory policies or interventions in more rural areas than urban areas. So I think it's something, and it's not just in tobacco, it cuts across different health conditions. We have to do better in supporting the health of rural communities, especially around chronic diseases, chronic conditions, and the behavior patterns that engender them.
And then Samantha had just a comment to Tyler. She said, thanks for acknowledging the limitation that NISDA survey only asked for sex, not gender and sex. It would be great to see more surveys adjust to add 2 questions for sex and gender in the future.
Agreed.
And that's it for
Agreed.
the online questions.
Just piggybacking on Samantha, it's a while since I looked at it, but I think the University of Washington's county by county map, I think it showed that there was like an 8-fold difference between New York State and Vermont. I may have my source wrong for smoking during pregnancy. Are you familiar with that level of disparity, or I'm reaching back into my memory
What
here?
direction?
New York State being much less than Vermont. And
Vermont has a pretty high rate of smoking during pregnancy. I honestly don't know how it compares to New York, but and it's changing. I think there are steps being taken by the Department of Health that are helpful. But there was a comparison across states a few years back where Vermont was not in the company that you'd want.
yeah, it was,
terms
I
of,
think, right there with, if I remember correctly, West Virginia
I think so,
and
Kentucky. yeah.
Kentucky, right?
And it drove action. I mean, I remember talking to our Vermont Department of Health officials about that. Like, we all agreed, this is motivation. We need to do more.
Right.
And when I was looking more recently, Vermont, I think the relative position has improved, but I can't tell you exactly. where
And
it's
so I was just, I guess my poorly formed question, but just as that I know that Vermont, by some measures of rurality, is considered among the most rural of all 50 states.
Yeah.
Because of just the sheer number of towns of very low populations. And so, of course, New York, has major, large numbers of large metropolitan regions. And I just didn't truly speculatively here, but I guess the question would be, whether you looked at New York State rural versus Vermont rural, whether it would actually be closer than. So that's all. I was just pondering that.
That's a very reasonable hypothesis, but I've never
Yeah, but-
made the comparison. Yeah.
The other thing I just wanted to share is Truth Initiative helped us to determine that Vermont is receiving the second highest number per capita of coupon direct mailed advertising. And it's known that, I believe, that women are more likely to use those coupons than men. So I just throw that out there as just a interesting point. It may have no bearing on
Oh, you bring up a good point. One of my favorite points. I'm a little rusty on my numbers, but I encourage any of you to just Google how much money do tobacco manufacturers in the United States spend on coupons per year? It's billions. And they don't do that just because they like to waste money. So they do that to manipulate what's known in behavioral economics as unit price. So if we make it more difficult to access cigarettes, then they decrease the price. And so the effort is, we're making it more difficult in terms of fewer retailers available in an area, but then they will make it less expensive so it can be a wash. So they're really sensitive to these behavioral economic factors that we're trying to bring to the scientific and the public policy communities. But the tobacco manufacturers are really sophisticated and they manipulate them. And coupons is one way they do it, and they spend a lot of money on it.
They were also placing these ads on webzines that were specifically aimed at new parents and pregnant women.
Yeah.
Specifically on those websites.
Yeah, they're ruthless in that regard.
One more question
Sure.
here. This one's for Tyler, although Steve, you may have some thoughts on this as well. I'm curious, in your cumulative disadvantage analysis or in your read of the literature, whether you think that vulnerability or risk for tobacco use is evenly distributed across those different disadvantaged, different disadvantages, or whether one may be carrying sort of more risk or be driving that relationship more than the others, either in your analysis or some of the others that have been conducted.
Yeah, I mean, and Steve and I can talk about this one quite a bit. It comes up in a review all the, is it, and we actually in that paper under review have Fong Fong's eloquent analyses showing for each risk variable odds ratios with those associations. And the general takeaway point that I try to make is that, someone will ask like, what's the most predictive, or is one of these variables most predictive? But across the documented studies now looking at cumulative disadvantage as a model, the overwhelming data shows it's that accumulation of these various risks as a prominent risk factor where those odds just drastically, like with those data, the odds drastically increase as that number goes up. Doing a detailed analysis of like for that group in 5+, what are the common themes across them? You could probably start to discern some potential patterns, but it's kind of one of those compounding effects. So someone that's engaged, a youth that is engaging in cannabis use probably has a higher likelihood if you take the outcome of binge drinking to see that also so that some of those interrelations. And so that's where the model sort of flips it and says it's this accumulation as an important factor. Yeah.
Hey, my question is for Grace. I'm wondering, you mentioned that some of the TikToks were talking about healthcare professionals suggesting that pregnant women switch from smoking to vaping. I was just hoping you could maybe speak a little bit more on that.
Yeah, so these are hearsay. So like people just when they're just sharing information, they're just saying like my doctor told me blah blah blah. And like that's what they're saying. We do see some evidence of these doctor influencers who kind of come on and talk about smoking and e-cigarette, like they do talk about that. So there is some evidence of that. But it was just people sharing information that they heard.
Got you. And those doctors, were some of those like doctor influencers talking about that specifically, like switching from smoking to vaping as a harm reduction strategy for pregnant women?
I don't think so. I do not think they were talking specific about switching. But again, it was few, right? So, but yeah.
All right, thank you.
Yeah, thanks.
I have a question for Grace. Before your presentation, I never knew about this relationship between vaping and fertility. What are they saying about that?
Yeah, that was interesting. So I also looked it up actually because
Yeah,
I was
that's what
also
I'm wondering.
curious. I think there is some evidence that there is a lower fertility both male and female
If you vape,
if you vape. Yeah. That's why I saw,
Interesting.
I was also had the same thought, like with how truthful is it and that. And that was interesting is that then you you drill it down and put on social media and how they interpret it. It's like, maybe this is a good for, birth control method,
that's what I want.
serves a multi-purpose. And the danger of that is, who are the people who are viewing it, who gets influenced? It's really the younger people. So it's a little
Right.
concerning. Yeah.
One more follow-up question. When you looked into it, was it vaping specific or nicotine use or, like smoking? Does that have a,
Yeah.
I think I remember smoking and women's fertility.
Yeah.
Yeah.
I think men's too.
Men's too.
Yeah.
Okay.
Because of
Yeah.
cardiovascular
Okay, very
effects.
good.
Yeah. And the studies I read had e-cigarettes. I don't know the comparative,
Right.
comparison to
Yeah.
it. Yeah.
Yeah,
Okay.
I don't think it's enough to consider it a birth control method.
Right.
I have to admit, with TikTok, I had some images going through like, oh, I'm vaping now. I can't, no. I didn't know what, but so it isn't as crazy as it might initially sound, but
taken to an
certainly
extreme,
no
yeah.
suggestion about using as contraception.
Right. Grace, I have a question for you. You mentioned in your future directions about the need to combat misinformation on social media. Do you have thoughts about it specific to this topic or more generally, or know what sorts of efforts are being made to try to do that?
Yeah. So there is a lot of effort to do that. It's difficult.
Mhm.
Especially, so I've been thinking about this with youth vaping
Mhm.
situations. The difficulty with social media is that all the comments could kind of undermine some of the
Mhm,
messages,
mhm,
right?
mhm.
So I personally have been thinking about how to do this in a better way. But I having said that, I don't know the answers. But people have figured with COVID misinformation, it was rampant at the time. And what social media companies have done is whenever there was a misinformation, they would have like a pop-up right below it. So there is a way to use algorithm to identify some of the key misinformation
Mhm.
and have automatic messages that come up within the social media platforms. How feasible is it to do it in the real world? I don't know. That's the part I don't know, but there is way to do it.
Yeah.
Yeah.
Great.
Yeah.
That's good to know. It's possible.
It's possible.
Yeah.
It's just like, can we force, Meta
Right.
to do it? That's,
Right, yeah.
I don't know.
Other questions?
I have a comment. You would think that Tyler and I, well, Dana, I'll be quick. You would think Tyler and I, but the data that already have reviewed all the data together and whatnot, but some of the data that Tyler presented was, the details were new to me, because we were preparing for the conference and getting papers ready and whatnot. But anyhow, I thought there was good news in that data set, in that you're not finding the disparity in girls, the rural disparity in girls, where you saw what we have in the women, the adult women. It's just jumping off the screen. So can you say more about that?
Yeah, that disparity there was no significant effect there. And then even with the men, you see that gap really closing over
Yeah.
time. And so how much of that, that overall
Yeah,
finding is attributable to some of the early differences,
Yeah.
because that gap, it's close to closing
Yeah.
entirely there.
we give the youth a lot of grief about their e-cigarette use, but what they've done on cigarettes, not using them, is remarkable, and it's going to have tremendous health impacts down the road. So,
And one other thought was, I was just looking in the data too, in the National Youth Tobacco Survey does a really good job of providing up-to-date data. So they already have 2024 data. And Brian King had a point that he made from the data showing that compared to 2019, youth e-cigarette use is down to a third of what it was at its highest.
Yeah.
So you're already starting to see some tobacco control and regulatory and prevention and all these other sorts of efforts playing some sort of role.
but we really have given them a lot of grief, some of it helpful about e-cigarette use. But I have a feeling culturally, it was the e-cigarettes that allowed them to say, cool kids don't smoke cigarettes. we do this other thing. And because the drop in the smoking prevalence among youth is just remarkable.
And I think, yeah, it speaks to the point yesterday of what is tobacco use going to look like as those youth age, is a big question.
Grace, this is more of a comment. I try not to do that because we're here for questions, but there's a group out of Minnesota that's actually trying to equip youth with like digital health literacy. And so the idea is when they're kind of targeted with this misinformation, or maybe people are, even if they're not intending it. So like in the example, e-cigarettes for birth control, the youth would be equipped to think, you know, I should probably talk to my doctor or provider, you know, my parents about it. And so I think that might be an interesting kind of strategy that would go beyond the vaping issues to others as well.
Yeah, I think that's very important. I think, not just about vaping, just generally just getting so much information on social media. I think that's really important. Yeah.
Any other questions? Okay, before we break, I want to remind you that at 12:40 in this room, there's a lunch and learn session on innovative strategies to promote harm reduction in rural communities with the UVM Center on Rural Addiction. And so you have time to go get lunch, have lunch, and come back for that. So thanks once again for these great presentations, and we'll see you later in the afternoon.